Welcome to the deep dive. Today we're tackling a topic that's, well, sensitive for many, often misunderstood, but also incredibly common. Abnormal vaginal discharge, or the medical term is fluor vaginalis.
Exactly. And for this deep dive, we're taking a bit of a shortcut, actually. We're diving straight into the clinical guideline, the NHG standard here. This is basically the playbook GPs use.
Right, the document that tells doctors how to diagnose and manage these issues day in, day out.
Pretty much.
Yeah.
So you're getting the expert strategy direct from the source.
And our mission today is, well, it's clarity, isn't it? We want to cut through some of the noise, the online myths, maybe, and really get clear on the big three causes: bacterial vaginosis, candidiasis, and trichomoniasis, and maybe show how efficient diagnosis can be when you follow these expert guidelines.
Yeah, surprisingly efficient sometimes.
Yeah.
So let's define our terms first. Fluor vaginalis, it's any non-bloody vaginal discharge. It's different from what's normal for you. Could be the amount, the color, the smell.
And it might come with itching or irritation, too.
Correct. And just to be clear, we're focusing on these common infections today. We're not really getting into rarer things like, say, cancers or postmenopausal changes. That's a whole other area.
Okay, so first things first. How common is this? Because I think many people feel quite alone when they experience it.
Oh, it's incredibly common. One of the top reasons women see their GP for gynecological issues. The numbers are quite telling.
Yeah.
Overall incidence for discharge complaints is about 15 per 1,000 women per year. But get this, for younger women, say 19 to 24, that number jumps way up. It's over 35 per 1,000. So really common, especially in young adulthood.
Wow. Okay, that's significant. And you mentioned something earlier, or rather the guidelines mentioned something fascinating, that sometimes there's just no cause found.
Yeah, this is a big one. In about 30%, nearly a third of women who come in with discharge complaints, standard tests don't find a specific bacteria or yeast responsible.
30%. So what happens then? They're just called aspecific complaints?
That's the term used, yes. Aspecific complaints. It tells you their symptoms are real, absolutely, but the exact why remains, well, unclear from a microbiological standpoint.
That's kind of unsettling, actually. Suggests there's more going on than just these few bugs.
It definitely points towards the complexity of the vaginal microbiome. But okay, let's focus on what we do typically find, the big three.
Right. Let's start with the one most people have probably heard of, maybe experienced. Candidiasis, or VVC.
The vulvovaginal candidiasis, yep, the classic yeast infection, usually caused by Candida albicans, a type of yeast.
And the symptoms are pretty distinct.
Very. The hallmark is itching, often really intense itching, plus irritation, redness, soreness. And the discharge itself is typically white, quite thick, often described as like cottage cheese or curdy.
Okay. And importantly,
it usually doesn't have a strong, unpleasant smell. And it's incredibly common. Something like 75% of women get it at least once.
75%. Okay. Next up, bacterial vaginosis, BV. You said this one's different.
Fundamentally different, yes. BV isn't really an infection in the traditional sense. It's more of a disruption, a dysbiosis.
Dysbiosis, meaning an imbalance.
Exactly. The healthy bacteria, the lactobacilli, which keep the vagina acidic and protected, they decrease. And then other bacteria, particularly anaerobic ones like Gardnerella vaginalis, they overgrow massively.
And that's what causes the famous BV symptom.
The discharge, yeah.
Yeah.
It's typically thin, grayish white, coats the vaginal walls. And often, not always, but often, there's a noticeable unpleasant smell, sometimes described as fishy.
Right. And a key point from the guidelines, BV usually doesn't cause significant inflammation. No major redness or swelling like with VVC.
Generally, no. The tissue might look normal on examination, which is a really important diagnostic clue for the doctor. It helps differentiate it.
Okay. And the third one in the trio, trichomoniasis.
Trichomoniasis. Now, this one is an infection caused by a little parasite, a protozoan called Trichomonas vaginalis.
And crucially, this one is sexually transmitted, unlike the other two generally.
Correct. Always considered an STI. The discharge here can be quite different again, often yellow-green, sometimes frothy or bubbly.
Frothy, okay.
Yeah, and usually there's an odor and irritation too. But here's the tricky part with trichomoniasis.
What's that?
A lot of people who have it, maybe even most, don't have obvious symptoms. Asymptomatic carriage is really common, and it can last for ages, even years.
Wow. So you could be passing it on without even knowing.
Precisely, which makes testing important if there's any suspicion.
Okay, so we have these three main players, each with slightly different characteristics. A patient comes in. How does the GP quickly figure out what's going on without immediately resorting to, say, expensive lab cultures?
Well, the guidelines really push for simple, quick, and inexpensive methods first, especially for differentiating BV. The cornerstone for BV diagnosis is something called the Amsel criteria.
The Amsel criteria. Okay, sounds technical, but is it?
Not really. It's based on clinical findings.
Yeah.
You need 3 out of 4 specific signs to be positive to make a confident BV diagnosis right there in the clinic.
3 out of 4. So they can often skip sending a swab off initially. That seems efficient.
It is, because it focuses on the signs of that dysbiosis we talked about. So criteria number 1, the discharge itself. Is it thin, homogeneous, grayish white?
Okay, the look and consistency. Number 2.
Vaginal pH. Using a simple pH strip, they test the acidity. For BV, the pH is almost always elevated, greater than 4.5.
Right, because the protective acidic lactobacilli are gone. A normal pH is lower, more like 4.0 to 4.5.
Exactly. That low pH is protective. If it's normal or low, it points away from BV, and maybe more towards VVC, which actually prefers that acidic environment. If it's high, BV or trichomoniasis become much more likely.
Makes sense. What's number 3? You hinted it might be memorable.
Number 3 is the amine test, or the whiff test. You take a sample of the discharge, add a drop of potassium hydroxide, KOH, and, well, you sniff.
You actually sniff it still.
Yep. If it releases that characteristic fishy immunity eater, that's a positive test. It's highly specific for the byproducts of those anaerobic bacteria in BV.
Wow. Old school but effective, huh? Okay, and the 4th criterion.
The 4th is looking at a simple wet mount under a microscope. You're looking for clue cells.
Clue cell?
Yeah, they're vaginal epithelial cells that look like they're studded with bacteria, almost fuzzy because they're so heavily coated. Seeing those is the 4th sign. Get 3 of these 4, and the diagnosis of BV is pretty secure.
Okay, that's really clear. Now, let's circle back to something you mentioned earlier. Why isn't just culturing for Gardnerella the standard way to diagnose BV? It feels like it should be.
It feels logical, I know.
Yeah.
Find the bug, diagnose the illness. But remember, BV is about the imbalance, the whole ecosystem.
Right, the dysbiosis.
Gardnerella bacteria can actually be found in small amounts in many perfectly healthy women. They're part of the normal flora for some. So just finding Gardnerella on a culture doesn't tell you if it's causing a problem.
I get it. It's like finding a common weed in a garden. Doesn't mean the whole garden is overgrown and unhealthy.
Exactly. You need to know if the weeds have taken over and crowded out the flowers, the protective lactobacilli. Culture for just one species doesn't show you that overall picture, that ratio.
So the Amsel criteria give you that broader picture clinically. What about labs then? Is there ever a role?
Yes, definitely. If the clinical picture is unclear, or for research, labs can do what's called a Nugent score.
Nugent score?
Yeah, it involves staining a slide and meticulously counting the different types of bacteria, the good guys, the bad guys, the curved rods. It gives a score from 0 to 10. A score of 7 to 10 is considered diagnostic for BV.
More detailed, but probably slower and more expensive.
Exactly. And newer methods like multiplex PCR are coming along too. They can test for multiple bacteria types at once, looking at the balance. They're fast and sensitive, but still evolving. Amsel often remains the practical first step.
Okay, diagnosis makes sense. Now, treatment. Is it always necessary? I think I heard you mention a key principle.
Yes, a really important principle for both VVC and BV. Treat the symptoms, not just the presence of the organism or imbalance. The guidelines emphasize treating only if the patient has bothersome symptoms. Hinderlijke klachten is the Dutch term they use.
So if someone has, say, BV diagnosed on a routine check but feels totally fine?
The recommendation is generally not to treat. Let the microbiome try to sort itself out unless symptoms develop. Don't just throw antibiotics at it unnecessarily.
Okay, so assuming treatment is needed, let's start with VVC, the yeast infection. What are the options?
Pretty straightforward. You've got topical antifungal creams or pessaries, things like clotrimazole, miconazole. These are imidazolines put directly into the vagina.
Right.
Or you can take an oral antifungal pill, usually fluconazole, which is a triazole.
Is one better than the other?
Both are considered highly effective. The guidelines often express a slight preference for the topical vaginal treatments first.
Why?
Mainly because there's less risk of systemic side effects. You're putting the medicine right where the problem is. But oral is effective too, and sometimes more convenient for the patient.
Makes sense. Now, the home remedies. Yogurt, garlic, douches. We have to ask. What do your guidelines say?
Unequivocally, they advise against them. There's simply no good scientific evidence that things like vaginal douching, putting yogurt in the vagina or eating it, garlic cloves, tea tree oil, None of that is proven to work for VVC or BV.
And they could even cause problems.
Yes. Douching especially can disrupt the natural flora and pH, potentially making things worse or causing irritation. Same with harsh soaps. The universal advice for hygiene is simple. Wash the external area with plain water only. No soap inside, no douche.
Water is enough. Good to know. Okay, let's switch to BV treatment. When symptoms are bothersome.
The mainstays are antibiotics that target those anaerobic bacteria, primarily metronidazole, which you can take as pills or use as a vaginal gel or cream.
Okay.
Or another option is clindamycin, usually as a vaginal cream.
And how long does treatment usually last?
For oral metronidazole, a common course is 500 milligrams twice a day for about 7 days. There's also a single high-dose option sometimes. The vaginal treatments are often used for 5 to 7 days too.
Are the pills or the creams better?
The guidelines generally consider oral and local treatments equally effective, so it often comes down to patient preference, potential side effects, convenience, that sort of thing.
Now, metronidazole, there's a really important warning that comes with that one, isn't there?
Absolutely crucial. You cannot drink alcohol while taking metronidazole, and you need to avoid it for at least 48 hours after your last dose.
Why? What happens?
It can cause something called a disulfiram-like reaction. Think intense nausea, vomiting, flushing, headache, heart palpitations. It's really unpleasant and potentially serious. So no alcohol is a strict rule.
Definitely noted. Okay, what about partners? If someone has BV, should their sexual partner be treated too?
This is a common question. But for bacterial vaginosis, the evidence is pretty clear. Treating the male partner does not seem to prevent the BV from coming back in the woman. So routine partner treatment for BV is not recommended.
Interesting. But that's different for trichomoniasis, right? Because that is an STI.
Exactly. For trichomoniasis, partner treatment is essential. Both partners need to be treated, usually with metronidazole, at the same time to prevent passing it back and forth.
Okay, that distinction is important. Now, let's talk about special situations. Pregnancy comes up in the guidelines quite a bit.
Yes, BV in pregnancy is complex.
I found the notes on this almost contradictory. Can you walk us through it? BV is linked to risks, but treatment isn't always advised.
It is a bit of a paradox, you're right. So we know that having DV during pregnancy is associated with a slightly increased risk of things like preterm birth or late miscarriage. That's the established risk factor.
Okay, seems like a good reason to treat it then.
You think so. But, and this is the crucial, but large studies have looked at treating pregnant women who have BV but don't have symptoms with antibiotics.
Yeah.
And those studies have generally not shown that the treatment significantly reduces the risk of those adverse pregnancy outcomes.
Wow. So having it raises risk, but treating it if you're asymptomatic doesn't reliably lower that specific risk for the baby.
That seems to be the current understanding based on the evidence. It's frustrating, but that's what the data suggests.
So what's the practical advice then? When do you treat BV in pregnancy?
The recommendation is basically the same as outside of pregnancy. Treat it if the woman is experiencing bothersome symptoms. The goal becomes relieving her discomfort.
Using what? Are the treatments safe in pregnancy?
Yes. Generally, clindamycin cream or metronidazole are considered options during pregnancy, though usually after the first trimester for metronidazole. The goal is symptom relief for the mother.
Okay, that clarifies that tricky point. What about recurrence? This seems to be a huge issue for both VVC and BV.
Oh, absolutely. Recurrence is incredibly common and frustrating for patients and doctors alike.
Let's take recurrent VVC first. More than 3 yeast infections a year. What's the approach if standard treatment isn't working long-term?
If someone keeps getting VVC despite standard treatments, the first step is often to confirm the diagnosis is correct. Then, the guidelines suggest considering if it might be caused by a different Candida species, not albicans.
Like what?
Like Candida glabrata. It's less common, but can be more resistant to the usual azole antifungals like fluconazole.
So you might need different tests or treatment.
Yes, you might need specific cultures to identify the species, and treatment might involve different antifungals, sometimes for longer durations. Consulting a microbiologist or gynecologist might be needed here.
Okay. And for recurrent BV, when the metronidazole or clindamycin clears it up, but it just keeps coming back, are there other options? The guidelines mention probiotics and vitamin C.
Yeah, this is where things get a bit less clear-cut. Probiotics, either oral or vaginal, have been studied, but the evidence is, well, it's limited and inconsistent for actually treating an active BV infection or preventing recurrence on their own.
So probably not harmful, but maybe not that helpful.
That's a fair summary. They might offer some benefit alongside antibiotics for some people, but they're not a standard proven fix and often not covered by insurance.
What about vitamin C, vaginal vitamin C?
This is interesting. There is some evidence, mostly from smaller or industry-funded studies,
Yeah.
suggesting that using vaginal vitamin C tablets after successful antibiotic treatment might help reduce the risk of BV coming back.
How that works?
The thinking is it helps to lower the vaginal pH, making it more acidic and therefore more hostile to the BV-associated bacteria and more friendly to the good lactobacilli, trying to restore the ecosystem balance.
So is it recommended?
It's not a primary recommendation because the research quality isn't super high, but the guidelines suggest for women with very frequent, frustrating recurrences, it could be considered as something to try in discussion with the patient. It's low risk, but again, usually an out-of-pocket cost.
A potential maintenance strategy then. What about just staying on antibiotics long-term, like a low dose?
That's sometimes done for very severe cases, what's called suppressive therapy. For example, using metronidazole gel maybe twice a week.
Does that work? Does it finally cure it?
It reduces recurrences while the person is using it. That's the key thing. The studies show the benefit is largely lost once the suppressive treatment stops.
Ah, so it controls it but doesn't fix the underlying problem.
Pretty much. And staying on antibiotics long-term, even low dose, increases the risk of side effects. And importantly, it significantly increases the risk of developing VVC, a yeast infection, because you're constantly disrupting the flora. So it's a trade-off, usually reserved for really difficult situations. Recurrence is definitely the weak spot.
Understood. Before we wrap up, let's just quickly touch on STI red flags again. When should symptoms make you think beyond VVC or BV?
Definitely. If there's easy bleeding from the cervix, like during intercourse or an exam contact bleeding, or bleeding between periods, or if the discharge is particularly foul-smelling, yellow-green, or pus-like.
Those suggest maybe chlamydia, gonorrhea, or trichomoniasis.
Exactly. Those symptoms warrant specific STI testing, usually with PCR swabs, not just relying on the Amsel criteria.
And seeing a specialist is a gynecologist. When does that typically happen?
Usually only if the symptoms just aren't clearing up, despite trying the standard guideline treatments. Or if the GP suspects something less common is going on, maybe a skin condition affecting the vulva, or rarely something more serious like a precancerous change.
Okay, so let's try and summarize the key takeaways for you, the listener. We've learned that diagnosing common discharge issues often starts simple Amsel criteria, pH testing rather than complex labs.
And that treatment, particularly for BV and VVC, should really be driven by whether you're actually bothered by symptoms.
Right. And hygiene. Simple water is best. Avoid douches, soaps inside, and maybe be skeptical of many natural remedies like yogurt or garlic, as the evidence just isn't there.
Yeah, and thinking bigger picture, while we have decent ways to treat acute episodes of VVC and BV, preventing them from coming back is still a huge challenge.
Yeah.
That 30% with no clear cause, the high recurrence rates, it shows we're good at putting out the immediate fire.
But not great at stopping the house from catching fire again.
Something like that, yeah. We understand the pathogens, but understanding and managing the long-term balance of that whole vaginal microbiome, that's the real ongoing mystery.
Which leaves us with a final thought, perhaps. Given that these guidelines focus heavily on identifying known bugs and using short-term treatments, especially antibiotics, what other factors, maybe lifestyle, environment, things beyond the scope of these standard guidelines, might be truly key to maintaining that delicate internal balance long-term and finally cracking the code on recurrence?
Something to consider. Until next time.